So if you want more information about SRNM, you can connect with us or with the Lucknow chapter of IIPN, Ranu Singh. She is looking after the SRNM conference on behalf of IIPN India. Till Sir joins, I think we'll go ahead with our program, and Aarti and Pia, you can take over, and I would take the first session, and Sir can join us later.
Okay, ma'am.
Yep, Pia, can I have you here, please? Pia,
am I audible?
Yes, you are audible now. Yes.
Yes. Yes. Should I start?
Yes, ma'am.
Yeah, Pia. Aarti, you can just change the slide, please.
Yeah.
Ladies and gentlemen, on behalf of IIPN India Nasik chapter, I, dietitian Pia Haldankar, welcome you all. It's honor to host this webinar for today. About Nasik, you must all be knowing about Nasik is an ancient holy city which is known for its link like Ramayana, Kumbh Mela, and Godavari River, which is Panchvati. IIPN India Nasik chapter is established in the year 2019, and it hosts multiple activities. Groups aims to latest knowledge in the field of nutrition and make an effort to spread awareness about nutrition health amongst all. The topic for today is revitalizing renal care, that is a nutrition odyssey to make renal care stronger, healthier for long journey or experience. And so, not wasting much of your time, I would like to introduce our moderator, Aarti Billare ma'am. She's a dietitian at Tata Memorial Hospital, Parel, worked as a dietitian at SL Raheja Hospital, recipient for the Best Mini Oral Presentation at 3rd International Cancer Congress 2023. She has published various papers about food developed. So now I would request Aarti ma'am to introduce our speakers for today's webinar. Over to you, Aarti ma'am.
Thank you, Pia, ma'am. Good evening, everyone. I extend my warm
Just
welcome.
1 second. Sir's there, so I think we can start with his presentation first, and then I'll follow.
Okay, ma'am. Yes.
Thank you.
Good evening, everyone. I extend my warm welcome for today's enlightening session on revitalizing renal care on Nutrition Odyssey, which is hosted by IIPN Nashik chapter and IIPN Renal Nutrition India. As we all know, chronic kidney disease is a long-term condition and is a condition where the kidneys are damaged and less efficient at performing the functions. The kidneys are responsible for a series of life-sustaining mechanisms which gets affected in the CKD, and it increases the risk of malnutrition in these patients. It's a very complex condition that places a unique set of demands on the body. CKD patients are at an increased risk of other health conditions like diabetes, hypertension, and it also increases the prevalence of mortality. It's a very important to understand that food plays a critical role in the managing the CKD condition. So the nutrition choices have the direct bearing on progression of CKD and the overall well-being of the individuals and their ability to cope with the challenges that come their way. So understanding the nutrition, the role of nutrition in CKD is not only what we should eat, but it also involves the holistic approach that consider the individual's dietary need, medical treatment, and the dynamic nature of the disease itself. So proper nutrition not only helps in the managing the symptoms, but it also helps patients to, it also contribute significantly to slowing the progression of CKD, improving the quality of life, and reducing the complication. So it's my distinct pleasure to introduce our first speaker, Dr. Devdatta Chafekar, who is a pillar of the field of nephrology and a guiding light in the renal care. Dr. Chafekar is not just a consultant nephrologist and a director of Supreme Kidney Care in Nashik, but he also holds an esteemed position of chairperson at IIPN Renal Nutrition India. With a remarkable career spanning over 3 decades, he has been a beacon of expertise in nephrology. In addition to his role at Wokat and Sahyadri Hospital as a consultant nephrologist, Dr. Chafekar imparts his wealth of knowledge as a professor of medicine at B. Pawar Medical College, Nashik. His commitment to advancing healthcare extends beyond clinical practice, evident in his editorial role for the online bulletin IVTR focusing on healthcare and medicine. As a member of both Indian Society of Critical Care Medicine and the Indian Society of Nephrology, Dr. Safikar has actively contributed to the medical community. His dedication and contribution have not gone unnoticed, earning him various awards, including the fellowship awards. Beyond clinical practice and academic, Dr. Safikar has shared his insight at numerous national conferences, holding a significant post in various medical associations. With a string of publications to his name, he continues to shape the discourse in the nephrology. So before starting the session, it's a request to all the participant to actively participate in the session, as your participation will make this session awesome. So without further delay, let us warmly welcome Dr. Devdatta Safikar, whose wealth of experience and contribution promise an enlightening session on nutrition care in chronic kidney disease. Over to you, sir.
Yeah. Thank you for that kind introduction. I am audible?
Yes, sir, you are audible.
Yeah, thank you. So I think we are starting with this webinar series on behalf of the Renal Nutrition India. And our endeavor would be to carry this knowledge forward for all the people who are interested in renal nutrition and to discuss the nuances of nutrition therapy as far as patients with kidney disease is concerned. I sincerely believe that all nephrologists must see to it that proper nutrition care is given to their patients, and nutrition should be considered equivalent to the medical therapy. It's one of the pillars of patient care as far as patient management is concerned. So we have to take it as seriously as possible. And I'm sure that it would make a world of a difference as far as the ultimate outcome of the patient is concerned. So with that, let me tell you that I'm going to talk to you about, in general, about nutrition care in CKD. And this is going to cover a few aspects of CKD. And I'll try and be general initially and then specific later. Now, let me tell you what are the common nutrition rules. What are the common nutrition rules? Whenever there is a disease state and the kidneys are affected, then renal function is compromised. And therefore, excretion of various substances which are not required by the body, which are normally excreted, that is compromised. And therefore, there would be accumulation of fluids, electrolytes, phosphorus, and other toxic waste. Also, the disease states can give rise to weakness, and also there is muscle and tissue breakdown. So therefore, there is the energy intake which is high and that is required. And remember that the protein intake is variable. So therefore, the principles of nutrition, they revolve around all these physiological changes which occur as far as the patient is concerned. What is the biggest challenge in meeting nutrition demands? One is that the nutrition should be balanced in each meal. So, not every meal has all the nutrients in a balanced manner. The second important thing is quality of nutrients. So, not all carbohydrates are equal, not all proteins are equal. Third is the emotional stress of the disease. So, remember that if there is an emotional stress, then it is going to affect the intake as well as the nutrition. Loss of appetite and enthusiasm also affects nutrition, and alteration in taste because of the metallic taste due to antibiotics and other treatments also would affect nutrition. So there are various factors when a patient is sick because of kidney disease that nutrition would be affected. And therefore, of course, all of us know that there is a need for nutritional support in patients with renal disease because malnutrition is very common. And there are many studies to show that if you do the right intervention at the right time, then you will get a positive outcome. So I'll quote a few studies as far as what is the need for nutrition support in renal disease. So this was published way back in 2014 in the Journal of Medical Nutrition and Nutraceuticals. And there they showed that 40 to 70% of patients with end-stage renal disease are malnourished. This is due to various factors like loss of appetite, impaired digestion and absorption, metabolic acidosis, emotional stress, and many other factors. Another publication, diets and nutritional supplements for improving outcomes in chronic kidney disease. Again, they made a statement that protein energy wasting, or PEW, is manifested by low levels of serum albumin and prealbumin. There is sarcopenia and weight loss, and this is one of the strongest predictors of mortality in patients with CKD. Now, as far as the pre-dialysis CKD patients are concerned, we must know how to diagnose and screen for the correct nutritional status. So all of us are aware of the KDOQI guidelines published by the Nephrology Society, and these are the clinical practice guidelines for not only for nutrition, but for all renal diseases. And KDOQI states that you must try and assess the nutritional status for pre-dialysis patients of CKD, and this should be measured or evaluated by a panel of markers which include edema-free actual body weight, normalized protein nitrogen appearance or dietary interviews and diaries, as well as serum albumin. Now, all of us know that malnutrition in patients with CKD is a very big topic, and it's a major issue. And this is going to affect the mortality, morbidity, functional activity, as well as the quality of life of the patient. So another study showed what is the need for nutrition support in patients with renal disease. So PEW, or protein energy wasting, is common in patients with chronic kidney disease, and it is one of the strongest predictors of mortality in patients with CKD. 18 to 75% of patients undergoing maintenance dialysis therapy show evidence of wasting. So therefore, dietary interventions and nutritional support seem to be effective in correcting protein energy wasting and improving outcomes to improve the longevity. So therefore, all of us should be aware of the syndrome of PEW and what happens if the patient is affected by PEW. So what is PEW? The International Society of Renal Nutrition and Metabolism, which is ISRNM, it defines the term PEW as a state of decreased body stores of protein and energy fuels, which means body protein as well as fat masses. So it's a distinct condition in CKD, one of the strongest risk factors for mortality and morbidity, and it is associated with reduction in the renal functional capacity, or it is also associated with progressive renal disease. What is the prevalence of PEW in pre-dialysis CKD patients? It is common. About 20 to 70% of patients undergoing maintenance dialysis therapy experience PEW. It is more pronounced in stages 4 and 5 of the CKD among the elderly. And in stages 3 and 4, it is prevalent to the extent of about 12 to 14%. A study conducted in 53 patients with stage 4 and 5 CKD reported 12% prevalence of malnourishment. I'm sure that in the Indian context, this figure is very, very high. And we see patients with PEW to the extent of 40 to 50%. So therefore, the Western studies are slightly different as compared to the Indian studies. Now, when we talk of PEW or protein energy wasting in pre-dialysis patients, there are many reasons why these patients get PEW. So you can get PEW because of disease states like infection, chronic infection, cardiovascular disease, frailty and depression. Then metabolic derangements like metabolic acidosis, insulin resistance, CKD MBD, which is mineral and bone disease. Of course, one of the most important factors of PEW is loss of your kidney function causes uremia. That causes reduction in dietary nutrition intake. Also, chronic inflammation and catabolic state also contributes to protein energy wasting. Now, what is the correlation between protein energy wasting and advanced stages of CKD? Remember that whenever there is CKD, there are many things which are happening simultaneously. So there are nutrition restrictions because of decreased nutrient intake. There is increase in the leptin level, and therefore that also contributes to protein energy wasting. Inflammatory cytokines like IL-1, IL-6, TNF-alpha are also increased in patients with CKD. It is seen that this could be a chronic inflammatory state. Metabolic acidosis, vitamin D deficiency, altered glucose homeostasis, as well as increased activity of mitochondrial uncoupling proteins. All these contributes to proteolysis, and ultimately proteolysis causes protein energy wasting. So proteolysis means also means there is increase in the resting energy expenditure, compounded by decreased nutrient intake, and catabolic state also contributes to the protein energy wasting. So it is emphasized that protein energy wasting is a very important phenomenon as far as patients of both dialysis CKD and pre-dialysis CKD. Now, what are the methods to evaluate protein energy wasting? First is the nutritional intake measurements. So direct measurements in the form of dietary recalls, diaries, and questionnaires. Indirect measurements is based on the NPN, which is non-protein urea nitrogen ratio. For example, 24 hours urinary urea collection can also tell you about PEW. The second way to evaluate PEW is body mass composition. So weight-based measures would be BMI and weight to height ratio. Skin and muscle anthropometric measurements would be skin fold thickness and muscle mass, and total body potassium, total body nitrogen. Then you have imaging techniques like the DEXA scan, the BIA, CT, MRI, etc., etc. And then you can also do some body density testing methods like underwater weighing and air displacement. There are some laboratory measurements which will also tell you how to diagnose protein energy wasting. For example, you look at serum albumin, pre-albumin, and the transferrin levels. Look at the lipid levels like cholesterol and triglyceride. Also, serum creatine and urea. You can also do the leptin levels, lymphocyte count, CRP, IL-6, TNF-alpha. So all these are parameters which could be biochemical or inflammatory parameters which can tell you about evaluation of protein energy wasting in these patients. And then there are some indices or scales which are also going to tell you the same thing. So there is something called as SGA or Subjective Global Assessment, which is a conventional or modified for renal failure. And there is a malnutrition inflammation score or the MIS score. So what are the ISRNM criteria for evaluating PEW? Some of them I have already told you. One is the serum albumin, which is less than 3.8, cholesterol less than 100, that is serum chemistry. Then you have the body mass, so BMI less than 23, total body fat percentage less than 10%, and unintentional weight loss over time more than 5% over 3 months or 10% over 6 months. Then there is criteria related to muscle mass, like reduced muscle mass, 5% over 3 months or 10% over 6 months, as well as reduction in mid-arm circumference area by more than 10%. Then you have the dietary intake criteria, like for example, the low DEI less than 25, and all these put together can also tell you about PEW. So in front of you in this slide is projected the SGA or the Subjective Global Assessment. Now this is a well-known chart which is known to all the nutritionists, and it has so many questions which can be asked. What is the weight change? What is the change in dietary intake, presence of GI symptoms? And there is a scoring system. And if the score is between 1 to 14, it is well-nourished. 15 to 35, mild to moderate malnourishment. 36 to 49, severe malnourishment. So depending on higher the score, worse is the nourishment. And this is the SGA score. Similarly, you have the MIS score. Now, this is validated as a better nutritional indicator than SGA because it is reported to correlate with morbidity, mortality, hospitalization, as well as nutritional and other inflammatory variables. It is fully quantitative score and uses 7 original SGA components, and it also has additional 3 new components like body mass index, serum albumin, and serum TIBC. Each MIS component has 4 levels of severity. 0 is normal, 3 is very severe, and the final score can be between 0 to 30. So therefore, HGA is more of a clinical judgment and MIS is more of a quantitative judgment. And we believe more in the quantitative judgment or the objectivity of the matter as compared to the subjectivity. So therefore, MIS is supposed to be a better score because it has some indices which are in addition to the clinical question. Now, what is the frequency of nutritional assessment which is recommended? In patients with GFR of 30, that is CKD stages 3 to 5, it should be done every 1 to 3 months. And if the GFR is between 30 to 59, you can do it once in 6 months. If the GFR is more than 59, you can do it once in 12 months. Now, as far as non-dialysis patients are concerned, remember that always you must do the serum albumin, the normalized protein nitrogen appearance or PCR by dietary interviews and diaries, and the edema-free actual body weight or the standard body weight. Also, in patients who are on dialysis, remember that serum albumin should be measured monthly. Then the percentage of standard body weight should be measured every 4 months. HGA should be done every 6 months. Dietary interview should be done every 6 months. I believe that this should be done more frequently, once in 3 months in our patients, because our patients, they need closer watch and more supervision. So therefore, you have to monitor these patients quite frequently. Also, skin fold thickness, mid-arm muscle area, you can do a DEXA scan, you can do the other biochemical parameters. All of them are also recommended. So as once you have diagnosed the protein energy wasting and you have applied all the scores which I have already told you to diagnose protein energy wasting or to diagnose the nutritional status of the patient, then you must manage the patient properly as far as the nutrition goals are concerned. And what are the goals of nutrition management? One is prevention and treatment of undernutrition. Second is, of course, you want to correct all the metabolic disturbances. Third is you have to correct the electrolyte disturbances. Fourth is attenuation of disease progression through protein and phosphate restriction and prevention of the intestinal mucosal integrity and function. So, preservation of intestinal mucosal integrity and function. So these are the goals of nutritional management, and this one must remember whenever we are planning a nutrition intervention. So how do you implement the nutritional management? So one is focused communication. The nutritionist must have a very, very focused and sincere communication. Then you must use a personalized dietary approach. Remember that periodic monitoring of dietary intake is very, very important. And counseling regarding nutrition, renal nutrition education, as well as checking for adherence is very, very important. And this could be, of course, challenging, but it is entirely feasible. So if you want to improve the nutritional status in a patient with CKD and avoid malnutrition, then remember that avoid diet restrictions in patients with poor intake. So remember to look at the intake of the patient and then avoid dietary restrictions. Treat gastroparesis properly, achieve glycemic control, correct electrolyte abnormalities, and also treat for depression, because otherwise the intake will be very, very poor. So nutrition counseling, you may consider oral nutrition supplement, enteral nutrition by tube feeding in some patients, and in some patients, of course, parenteral nutrition is also required. Now, to prevent protein energy wasting, then for a healthy adult which is 50 years or older, this is the recommended nutrition intake. Protein 0.8 gram per kg per day, energy 30 to 40 kilocalories per kg per day, sodium, chloride, phosphorus, and calcium, all the figures are in front of you. So the recommendations are different as by KDOKI, ISPEN, and for both dialysis CKD and pre-dialysis CKD, they're slightly different. For example, the protein intake for dialysis patients is higher as compared to pre-dialysis patients, and the SPEN, of course, recommends that if the GFR falls too low, then you are supposed to have a very low protein diet. The general recommendation for sodium, potassium is generally the same. The SPEN is more stringent as far as potassium restriction is concerned and phosphorus restriction is concerned as compared to KDOQI guideline. Now, remember that the recommendations for dietary and nutrient intake are provided as per the CKD stage. And sometimes only protein restriction doesn't work. So in that sense, you may have to supplement these patients with some essential amino acids or keto acid, even as recommended by the current guidelines. So protein restriction along with supplementation with essential keto amino acids is also recommended. So the SPEN recommends that energy intake should be 35 calories per kg per day. Then the protein intake for GFR less than 25 is 55 to 65 milligram per kg body weight, plus supplementation with essential amino acids. The minerals, phosphate is 600 to 1 gram, potassium 1500 to 2 grams, and sodium 1.8 to 2.5 grams. Then elderly patients may require a different formula, and you should use standard formulae, but you should also tailor-make these formulae, and you should use all the supplements judiciously. So again, to compare between KDOQI and SPEN as far as CKD stages 3 to 5 are concerned, they are almost the same, but there are some differences which I have already alluded to. Also remember that adjust the protein intake according to the CKD stage. So you have LPD, which is low protein diet. In dialysis patients, it is HPD, which is high protein diet. And then post-transplant, it is standard protein diet. So remember that the protein intake will differ according to the clinical condition. This is again as per the creatinine value, what is the protein intake. You can have LPD, which is 0.5 to 0.6 gram per kg body weight per day. You can have VLPD, which is 0.3 to 0.4 grams per kg body weight per day. Remember that the energy requirements are still high. So therefore, do not reduce the energy requirement, though you are reducing the protein intake. What is the effect of protein restriction as far as the GFR and kidney function is concerned? There are various advantages, and there are many studies to show that. Remember that if you are exposed to a lower protein load, then the GFR is supposed to be slightly better. Also, the urine protein excretion is slightly lesser with the lower protein diet. It basically means that there is less load on the kidney as far as the working capacity of the kidney is concerned, and then that is how protein restriction is going to be beneficial. It is also shown that protein restriction may delay GFR decline by an average of about 0.5 ml per minute per year. And this is a meta-analysis of all the low protein diet studies. 13 randomized controlled trials were studied, and they found that the low protein diet reduced GFR decline by 0.5 ml per minute per year. So therefore, protein restriction is very important. This is one of the seminal studies called as the MDRD study, published way back in 1994. And it showed that this was initially perceived as a negative study for protein restriction, and it was extensively criticized. However, ultimately, it was shown that protein restriction was definitely beneficial. So, progression of renal death and progression of fall in GFR is definitely different when you use a low protein diet versus a normal protein diet. Remember that non-dialyzed CKD patients may be consuming too much protein, and therefore the protein restriction is very, very important. What is the rationale and what happens if you reduce the protein intake? Not only you prevent further fall in GFR or slow down the fall in GFR, but you may also ameliorate uremic symptoms, then reduce the proteinuria, improve the metabolic profile, and that is how you are going to benefit the patient. There are some metabolic benefits as far as protein restriction is concerned. So therefore, remember that protein restriction also gives rise to lower phosphorus levels because it is linked to the phosphorus intake. Now, also it reduces the creatinine excretion. it also increases the bicarbonate levels and reduces metabolic acidosis. We must remember that metabolic acidosis is very, very important as far as progression of kidney disease is concerned and mortality and morbidity is concerned. So with metabolic acidosis, if it is reduced by reduction in dietary protein intake, it is going to be definitely beneficial as far as the patient is concerned. Low protein diet increases the bicarbonate level. Reducing saturated fatty acid from meat may improve the lipid profile. So therefore, protein restriction, that means giving him vegetable proteins as compared to animal proteins, is also going to be beneficial. So therefore, it also reduces the nitrogenous waste products and reduces the catabolic state. It also helps the blood glucose and the insulin levels. It improves the phosphate load, which is inherent in protein restriction, and it may delay the progression of renal disease and progression to dialysis. So here it is very clearly shown that if you restrict the protein to 0.6 gram per kg per day or lesser than that, then the hazard risk ratio of progression of kidney disease is definitely better as compared to if you do not restrict. So the algorithm should be that you restrict the protein, limit the dietary potassium, sodium, phosphorus, and remember that nutrition intervention is required if there is sarcopenia, if the protein intake is high, and if the electrolytes or the other metabolic parameters are out of range, and if the patient's renal function is declining very, very fast, if there is acidosis, and if the patient is sarcopenic. So all these are indications for nutrition intervention. So you must monitor the nutrition status and intervene at the right time by giving the dietary counseling advice, or you may initiate dialysis and then also do a nutrition intervention and then continue the treatment. There are many challenges which are associated with it. It is very easy to advise a low protein diet, but there are many challenges associated with the implementation of this for the simple reason that the patient may not adhere to the advice. So this requires frequent monitoring. Compliance is not easy, and you may have to give a lot of dietary exchanges, and these are the major concerns as far as the compliance is concerned. Now, it may be inconvenient for the patient, and this may result in worsening of the patient's nutritional status. So a periodic follow-up is very, very important. And at the time of periodic follow-up, you should do all the relevant tests to find out in what way the patient is improving. So in some patients, whenever there is protein energy wasting, but the patient is malnourished, then you give keto analog in addition to the protein restriction. So restricted protein alone can give rise to malnutrition, deteriorates the quality of life and worsens CKD, but keto analog will help you. So this is sort of a pyramid to tell you what are the alternatives as far as food items are concerned. So rice and alternatives, fruits and vegetables are the initial part, and then meat and alternative servings and fats and oils are the later part. But this is a standard dietary chart which is advised to people who are healthy and in whom the BMI is not maintained. However, please remember that this is not true for CKD patients. In CKD patients, I don't need to tell this audience what is the energy or protein content of milk, meat, vegetables, grains, fruits. All of you are experts in this. But in general, you should know how to calculate what is the content as far as one portion of food is concerned, and contents related to carbohydrates, protein, energy, sodium, phosphorus, and potassium. And then you can plan the diet as per the choice of the food item as well as the portion. So for example, the portion can be decided of milk, vegetables, grains, and fruits. And depending on that, you can also restrict the proteins. So generally, the prescription should be 70% of protein should be of high biological value, 0.6 gram per kg, and 1800 to 2000 kilocalories. the meal composition should be uh, calories and proteins and sugars separately. Now remember that protein is found in two types of foods, animal sources and plant sources. And some of these protein-rich foods may also contain high amounts of phosphorus. So I'm going to skip the whole portion, but the whey protein is very important for patients with kidney disease. Remember that most of the recommendations, they tell you that 50% of dietary protein should be of higher biological value. So whey protein does not contain.
Sorry to disturb you, sir.
Yeah.
But we are
Yeah,
running
go on.
short of time, and so
Okay,
that's
I'll
why
just
if you
try and
can wind up fast. Yes, sir. Thank you, sir.
Yes, so I'll just wind up in the next few slides.
Sure,
So
sir.
therefore, whey protein is very, very important. And some of these patients also require supplements. And remember that I will not go into the details of dietary recommendations as far as sodium, potassium, and the importance of leaching. And I don't need to tell you about what are the high potassium containing foods, which are the foodstuffs which are high in phosphorus. You must also always look at the nutrition facts and read about them whenever you are prescribing ready-made food items. And therefore, it's very important for us to remember that the need for nutrition support in renal disease is very, very important. And some of these patients, they require oral nutrition supplements. So to summarize my talk, nutrition status worsens as kidney function declines and as the CKD stage advances. Worsening nutritional status is associated with increased mortality and morbidity. You must monitor the nutritional status regularly, and therefore, from practical standpoint, you must have the right parameters which are going to help you to diagnose malnutrition. And dietary protein restriction is beneficial. Metabolic benefits are also there as far as this approach is concerned, but there should be close supervision and regular monitoring of the patient. Thank you very much. I'm sorry that I have exceeded my allotted time.
Thank you so
Yeah,
much, Dr. Chafekar. Thank you so much. So very nicely, Dr. Chafekar has explained how nutrition can be a cornerstone in the management of CKD, and it's not just beneficial, but also how much it's essential. He has also explained very nicely. He has brought a wealth of knowledge and experience to our discussion, and his dedication to advancing healthcare and particularly in the renal care, both inspiring and impactful. Thank you so much, sir. So without any further delay, we'll move to our next session. As we are running short of a time, we'll take a question answer session at the end of the session after Himani ma'am's lecture. So I'll introduce Himani ma'am. Okay. So our next speaker, Ms. Himani Puri, is a dynamic force at the intersection of nutrition, healthcare, and the human rights. So please join me to welcome the Chief Program Officer of IPN Renal Nutrition India, the Honorary Secretary of IPN India Nashik chapter, and the founder of proprietor of Sattva NutriCare, none other than our esteemed Chief Dietitian at the Apex Hospital Nashik, Ms. Himani Puri. So in her role as a program officer for the IPN Renal Nutrition Core Group, she not only works in healthcare, but also takes it a step further. She also she's also the secretary for Nashik district at the International Human Rights Organization. And in the digital world, she's an editor of the Healthcare and Medicine for Online Bulletin IVTR. Her extensive affiliations include membership and the life membership with IAPN, IDA, National Kidney Foundation, ISRNM, RSSDI, AIAARO, and SRNM. But the range of her impact extends even further. She is not only associated with the Archery Association of India, but she has also conducted a numerous nutritional training workshop and sessions for the archery coaches and athletes across the India in collaboration with the Sports Authority of India. So her commitment to inclusively is evident through her association with Paralympic Committee of India as a part of Para-Athlete Online Development Program. So let's also celebrate her role as a nutrition advisor to Grandmaster Mr.
Vidit Gujarati, and proudly acknowledge that two of her athletes represented India at the Tokyo Paralympic in 2021 and have already qualified for Paris 2024. So it's with a great anticipation and an honor that we welcome the accomplished Chief Program Officer, Secretary, Founder, and Chief Dietitian, Ms. Himani Puri, who is a truly multifaceted leader shaping and landscape of nutrition, healthcare, and sports. She'll be talking on burden of CKD and unmet need in the nutrition care. Over to you, ma'am.
Thank you so much, Aarti, for a generous introduction. And I'll share my screen now.
Yes, ma'am.
Yeah. Is my screen viewable to you, Aarti?
Yes, ma'am. It's visible.
Yeah, great. So, sir has very beautifully and nicely explained and very detailed about how the nutrition management for renal patients is to be done, whether it's CKD, conservative, or on dialysis. So, I'll be going a step further and discussing about why and how should we be dealing with the patients when they are coming to us with non-fulfillment of the nutrition goals that we are talking about. So, as we all know, CKD is slowly crawling up, and we are seeing more cases of CKD. We are seeing more mortality happening in CKD. A lot of patients, in fact, are going undiagnosed with CKD. A lot of patients are going without any treatment for CKD. So, therefore, it becomes more important for us to become more aware and talk about CKD not only in the clinical setup but also in the community level, because diagnosis of CKD is something which is not something a lot of people are working on and become a little complicated to work on at the community level. So as sir told about CKD being a multifaceted and a comorbid condition with a lot of other comorbidities involving around it. However, the main focus when we talk about CKD in terms of nutrition is one is cachexia and the other is PEW. So as you can all see that a lot of patients come with multiple dietary restrictions. So these restrictions again are going to worsen the condition of cachexia and worsen the condition of energy wasting. So the focus of the dietitian has to be overcoming these restrictions, overcoming all those hindrances and trying to improve the patient health. Also, fluid overload causes us to reduce the volume of the fluid intake. As a result, limitations come more where the diet management is concerned. There's a lot of increase in the inflammatory cytokine. So we have to be looking at diet which is actually anti-inflammatory and is going to be looking at the energy and the protein balance along with the fluid intake restriction. Anorexia, metabolic acidosis, anemia is a difficult step again. So patient is coming to you with anorexia with feeling of nausea and the patient does not want to eat much. So this also adds on to dealing with the dietary management of the patient. Of course, oxidation stress is increasing. A lot of other comorbidities like CVD, diabetes, infection can again be a further hindrance to our management. Vitamin D deficiency, elevated PTH in certain patients, and decreased insulin levels adds up to the glycemic control of the patient, and therefore we end up reducing the carb intake also in such cases. Nutrient loss due to dialysis also makes us to increase our intake, whereas restriction in the fluid makes it a challenge for us to give maximum amount of nutrients and minimum amount of fluid intake. Dialysis procedure sometimes itself can cause inflammation. Restrictions to timings also can be a hindrance to where nutrition management or diet intake of the patient is concerned. Loss of residual and loss of kidney function aggravates all other conditions. Metabolic acidosis sets in, and the further patient goes into a decline mode of health and quality of life gradually decreases for the patient. And of course, with this comes the physical restriction. The movement restricts, and therefore the patient does not want to eat much. Because of a result, he is not able to mobilize himself much, and he is not able to digest the food well. So what happens because of all this? Low nutrient intake, which of course causes malnutrition, or if the patient is already malnourished, the malnourishment worsens. Inflammation increases further, hypercatabolism sets in, and uremic toxins increase, which eventually lead to increase in infection. Cardiovascular disease can worsen, frailty, sarcopenia, and eventually the patient lands up into depression. It is not only the patient, but the caregiver or the family and the friends of the patient also who fall into that phase of depression. So when you're talking about nutrition management of the patient, it's not only the patient, but it is also the surrounding family members who need to be counseled when you're talking about nutrition management for patients in CKD. As a result of all this circle that we see of nutrition management happening, there is increase in mortality, increase in morbidity, and eventually decrease in the quality of life of the patient. So this is a beautiful explanation about how cachexia happens and what is PU and how do we differentiate between them. So the definition for cachexia is given by the Cachexia Consensus Working Group, and the definition for the PU is given by the ISRNM. As you can see in cachexia, there is unintentional decrease in the energy intake less than 20, as against an intentional decrease in the energy intake of less than 25 for at least 2 months in terms of PU. The albumin level less than minus 3.2 would address to cachexia, whereas our albumin level less than 3.8 can also categorize a person into being into PU. Usually in cachexia, we see a HB level below 12 and the inflammatory biomarkers are increased, whereas in PU, the cholesterol level would be decreased and we would be seeing a gradual decrease in the GFR value of the patient and also a lower value of prealbumin in the PU. Body mass, usually there is no statements given by the CCWG where the body mass is concerned. However, PU states that a total body fat percentage loss less than 10% can categorize the patient into being PU. Whereas for cachexia, the muscle mass can be checked and a reduced mid-upper arm muscle circumference less than 10 percentile and a decrease in the DEXA by 5.45 and 7.25 in males and in females and males can categorize to as being cachexic. However, there is no certain guideline given by ISRNM where PU is concerned regarding the muscle fatigue, muscle strength or fatigue. The dynamometer or the muscle strength is a very easy method to check for the muscle strength of the patient where cachexia is concerned. And we can classically categorize a person being into cachexic stage or into a PU by the weight loss of 5% in 12 months with underlying illness, plus any of these three categories being met. Whereas in PU, even if the person is meeting any 3 or 4 of the categories, the patient would be categorized as being into a protein energy wasting condition. So this can help us identify the category of the patient's malnutrition and therefore help us to improve and focus more on the better nutritional counseling for the patient. But once all this is done, as Sir said, we talk about the protein intake, we talk about the potassium intake, we talk about the energy intake. But next comes the major challenge is how you deliver this. How we manage to convert all these numbers into a plate and this plate is served to the patient and the patient accept all this. A lot of focus has to be done on to the counseling part here. And what are the disadvantages that we face or the problems that we face is one is the social disadvantage, economical challenges, and systemically marginalized conditions sometimes. So to go a step further, the first problem that we face is awareness or the lack of it. What I mean to say here is that how aware the patient is about his or her situation and how difficult it is or how easy it is for them to understand the gravity of the situation. One, do they have adequate knowledge about the food intake? Do they have adequate knowledge about the food portion intake? Do they have adequate knowledge about the food cooking method? So access to this information, awareness, when I say awareness word here, so awareness to all these parameters becomes very, very important when we start counseling the patient for diet management. So therefore, the focus has to be raising awareness. How do we raise the awareness? We assess the patient for their educational status, for their literacy level, for their education in terms of the healthcare system, and the priority in terms of health and the priority of his health amongst the family members. Also, we need to talk about the patient, as Sir said, about the animal protein, the sodium intake, the intake of the processed foods, and the intake of the foods which are going to actually increase the acid load. So this awareness is something that the patient should be made aware about, and the counseling is very, very important. Also, the patient should be educated that turning over to fresh fruits and vegetables is actually going to contribute to a further improvement in the health of the patient. Whereas I have a lot of patients who come to me when they come with the thing that they have to eat high biological value proteins. So what they understand is that they have to eat completely non-vegetarian and they have to leave off fruits and vegetables. A lot of people also come with the concept that fruits and vegetables have a lot of potassium, and therefore they stop down the fruits and vegetables completely. So this counseling, this awareness has to be done at the patient level and at the family level both. Next is the access to this information and absence of this information. This again becomes very, very important. When I talk about access could be access to a person who is going to give this information. That is access or absence of a dietitian in that setup, one. And second is access to the food or food insecurity. Both of these conditions are actually going to decrease the outcome or reduce the improvement outcome of the counseling here. So access to food is important. That has to be made sure. We need to counsel the patient depending upon the foods that are available to him easily, the foods that he can procure easily, and then counsel the patient, one. Secondly, a dietitian has to be present at least every renal setup. As Sir emphasized in his talk, the dietitian should be there looking at the dietary management of the patient. So these two things have to be accessible in the patient surroundings. The other is that we talk about is the ratio of the dietitian that we are looking at. This was a survey done in 2012 and it still holds true, which says that for every 1 lakh population, Indian population, we have just 0.3 dietitian. That is not even one dietitian for 1 lakh of patients. So we are looking at actually lower number of dietitians, but still the access of the patients to the dietitians is lower. This was a study published by our very own IPN journal, and it said that in accredited and non-accredited hospitals, for every 54 patients, there is only one dietitian, and in non-accredited hospitals, for every 407 beds, we have just one dietitian. So we are looking at the gross absence of the resourceful person at the renal setup. So therefore, as thinkers in the discipline of health, we must encourage, we must discuss with the patient about the quality of the food, the quantity of the food, and seek the help from a properly qualified professional, maybe a nephrologist or maybe a renal specified dietitian, so that they are able to get proper guidance. We should be also looking at and trying to overcome the various barriers like the financial barrier, the geographical limitations if the patient has any, the social barriers if we are able to overcome, try to do that, and also physical limitation that the patient has. Probably he is too fragile or too frail to walk up, or maybe he does not have anybody who can cater to his needs of food. So these are parameters as a dietitian have to be looked upon. The last point, the second last point which comes is about the affordability, which I said is very, very important. It is very easy to advise somebody something, but it is very difficult to put it in the budget form. So as a dietitian, again, it becomes very challenging for us to put everything, whatever is in the numbers, into the plate and into a limited amount of monetary terms as well. So this is something we should be looking at. Also, we should be focusing at the nutrition risk factors, because when you talk about affordability, affordability also comes with the affordability of the food. In India, we are now seeing either undernutrition or we are seeing overnutrition. And sadly for us, overnutrition, obesity is rising. But with this obesity, there is an increase in the other comorbidities, which in fact is actually causing an increase in the end-stage kidney disease. So therefore, as a dietitian, look at the nutritional risk factors, look at the socioeconomic risk factors, and then guide the patient for further management. And last point is accountability. Who accounts for all these things? Is it only we who account for this? Is it only the healthcare providers who need to be accounted for this? No, it has to be the patient himself, because eventually he or she is the one who's going to consume the food. So that accountability sense has to be explained to the patient also. That sense of accountability has to come to the family as well, because many a times that is what happens. I am explaining the patients everything, I'm explaining the family everything, but still the family ends up cooking what is convenient for them. So even they need to stand up and take accountability for the food that the patient is being served. The friends, yes, because they are going to be the bigger pillars and the motivators for the patient and his family. And society in large or community in large has to start doing it. Now, when I have patients coming to me and who are suffering with CKD, the major problem that they face is that they cannot eat healthy food when they are going in a restaurant, because they would not get anything which is potassium free. They would not get anything which is low in phosphorus, and none of the foods actually is looking at the salt intake or the sodium level also. So we as a society should be addressing these issues as well, and maybe try to have separate menus or separate counters for patients with renal disease, for patients with diabetes and other conditions, so that everybody is responsible and managing and looking after each other's health at a macro level as well. So lastly, providing nutrition care to the patient is a complex structure. I have just tried to put up everything in a very simplistic flow chart, which sir has already explained. So you assess the patient first for malnutrition, you screen the patient, you look at their intake of diet of protein and energy, you assess them for their biomarkers, you look at the SGA form, you look at the MIS form, and you get your assessment score. If on evaluation of that, we categorize the patient on the energy intake that the patient is taking, the protein intake that the patient is taking, and as per that, we come to a nutritional diagnosis. And after diagnosis, we come to the next part, that is we try to plan a diet for the patient, which we call as goal setting, or if you can remember, put it as SMART. That is, we try to be specific in what we are giving. We try to be measurable so that we are able to know the exact amounts of the food patient is consuming. Try to be achievable in terms of easy food assessment, so the easy food availability, so that we are able to achieve our targets. The food intake should be relevant and should be time bound, like probably 1 week, 2 week, or 3 week, whatever your categories are or your criterias are. We can go for a dietary protein intake of 0.8 with the keto analogs or with the amino acids or supplements if required. Or maybe for patients on dialysis, we can go to as high as 1.2 gram per kg body weight with ONS if required, depending upon the patient's requirement. And try to focus on exercise therapy for the patient if he or she is mobile and can try doing some physical activity at some normal level. Again, after that, we come to the last and important point, that is we evaluate. We evaluate the patient for improvement, no improvement, or deterioration, and thereby then decide what we need to do. Maybe the patient needs to go on dialysis. Maybe the patient is not adhering to the diet schedule that we are giving to the patient, or maybe we need to introduce some other way of improving diet, or maybe we might have to shift the patient from oral to tube feeding, or maybe if the patient is already on tube feeding, we might have to go in for supplemental nutrition, or maybe we might have to go for interdialytic parenteral nutrition if the patient is already on dialysis. So this assessment becomes very, very important, crucial part of our nutritional management. So lastly, potential elements to consider: look at the functional status, cognition, social background, patient-reported outcomes, the degree of the kidney functioning, nutritional status, life expectancy, energy habits, and dietary habits and energy intake. Based on that, optimize energy intake, optimize protein intake, look for the barriers, maybe cognitive or economic or drug interactions. Finally, assess and see if the goal is achieved. If no, then rethink again. Finally, communication is the key. To your patients, discuss with your patients, discuss with their family members, so that we are able to remove all the hurdles and overcome the challenges. So finally, let us recognize all the challenges and fight to unmeet the needs of nutrition in CKD. Thank you so much. Thanks.
Thank you, Himani ma'am, for wonderful session. Very nicely, you put the point that how, like, as we said, CKD should be managed holistically. We should have a holistic approach. So we all know that nutrition is important, but along with the nutrition, there are other factors which, as a dietitian, we should consider during the counseling is very also important. Also, you put one point that the society, how society can contribute to this patient, this renal patients. It's a really very good point that you put. And also, um, uh, even you mentioned that the counseling part. So it's not only important to counsel the patient, but it's also equally important to counsel the relative is also important. And it's a really good message to all of us that how we can manage the CKD as a holistic approach. Thank you so much, ma'am. So let's move to the question and answer session. We have some questions. Okay, the first question is to Dr. Safikar. I think you have already addressed, but we'll take this question as what tool do you recommend to assess the malnutrition in dialysis patient? Do we need to consider SGA, or is there any specific validated tool, especially for the CKD patients?
Yeah, I already answered, but I'll just repeat. Interestingly, we did a study in our medical college regarding this issue, and which is a better score. So we compared the SGA versus MIS, and we found that MIS is better because it has got some objective parameters. So therefore, we recommend that you use the MIS score as far as the patient assessment is concerned. In addition, you can also look at the ISRNM criteria for diagnosis of PEW, and that also will help you to diagnose this problem very, very early.
Thank you, sir. Sir, there is one more question that you mentioned about the whey protein. So there is a question that how practical it is to strictly restrict the protein in non-dialytic patients. For example, they are saying, for example, avoiding all the pulses, dals, eggs, milks, and giving only whey supplements.
So I agree that protein restriction is a very, very difficult thing to actually do it in practice. For the simple reason that the palatability of the food is also affected, number one. And I think the monotony of the food is also something which we should address as nutritionists. So therefore, it is not very practical to replace all the protein with whey protein. But if your predominant protein is whey protein, then there might be some advantage. So I would say that if, say, your protein intake is, say, 100 grams, example, then 70% can be whey proteins and rest of it can be other proteins. And that is how you can mix and match and manage. What is recommended is that if the whey protein can be utilized and digested and accepted, then it is better as compared to other proteins.
Thank you, sir. Ma'am, I think you can answer this question that for obese CKD patients, do we have to plan a low-calorie diet to maintain a normal BMI, or should we continue with the same as we have seen fall down in weight if dietary management is not done?
So one thing, Aarti, is that we do not look at the BMI when you're talking about the calorie intake. You could be looking at the adjusted body weight for this patient. And as per that, you can start with the calorie intake for the patient. Also, if the patient is losing weight, it could be the muscles which the patient is losing and not the fat which he is losing. That is something which needs to be checked up again, because we don't want the patient to lose muscles at this level. It has to be the fat which has to be lost. Yeah, so it's basically the adjusted body weight that we should be looking at for calories and the protein intake calculation.
Can
Okay,
I
I
tell
think
you something interesting in
Yes,
this
sir.
regard? So,
Yes.
there's a study carried out about mortality in patients on dialysis, and they found that the obese patients do much better as compared to non-obese patients who are on dialysis. So, I mean, longevity-wise and mortality-wise. So that is something which is very, very interesting. Normally, we are always looking at the BMI and the weight, but as far as dialysis patients are concerned, the obese patients do much better as compared to non-obese patients. And this is a published literature.
Oh, it's really nice and really very interesting. We can have a next lecture on this topic as well, how it's helping the patients. I think, ma'am, you have already answered this question that when we talk about the per kg body weights, especially in renal nutrition, we should consider actual weight or ideal body weight.
So if the patient is on the leaner side, you can go for the actual body weight for the patient. But if the patient is on the obese side, you can go for the adjusted body weight, because ideal body weight would be giving us a faulty intake. But again, if the patient on dialysis, we should be looking at the dry body weight of the patient and not the actual body weight that time for the actual patients.
Okay, thank you, ma'am. Um, just a second, ma'am. So there is one more question, as the protein has phosphorus. So in a dialysis patient giving high protein, how to control high phosphorus in dialysis patient if having already high phosphorus?
I think sir can answer that question.
Yeah. So
Okay.
in dialysis patients, it's recommended that you should not, restrict protein too much, because there's protein loss during dialysis and the patient can have PEW. However, if the phosphorus is high, then you should really be modifying your dialysis prescription as far as phosphorus is concerned. Secondly, look at the phosphate intake and also give the right phosphate binders. So there are lots of good medications now which are available which bind phosphorus in the diet, and that is how you are going to treat the hyperphosphatemia without restricting too much protein, because that is what is recommended. So short answer is that you do it by medications.
Oh, thank you, sir. There is one more question. As a severe restriction of protein, that is 0.3 to 0.4 kg per day, is advisable in case if patient's serum creatinine is 9 and is not eating properly, can cause body protein breakdown further. Like how we can manage this time, how we can manage the protein, how we can prevent the muscle loss in these patients.
So I'll just give my input and then, maybe
Yeah,
sir
go
can
on.
would add
Mimi.
further. Yes. So 0.3 to 0.4 is VLPD, which would be coming keto analogs, and sir would add further on that. But of course, giving a low protein diet is going to cause more muscle breakdown, and as a result, we would be seeing a further increase in the creatinine level. So it's not only 0.3, 0.4, it is 0.3, 0.4 with the keto analogs. I think sir can add further to this now.
Yeah. So, the debate is about VLPD and LPD and what happens if the protein intake goes so low that there is in fact addition to the hypercatabolic state. Now, in that sense, in Indian, now you must remember that the Indian scenario is different as compared to the European or the Western scenario. Now, Western scenario, the famous study by Ganiata et al., where they had VLPD along with keto analog supplements. So there they showed excellent results. But most of these patients had a normal BMI. They were not malnourished. If you look at the Indian patients, those who enter CKD or CKD care, most of these patients could already be malnourished. So to copy whatever has been advised by the Western literature, word to word, like for example, VLPD, is not in Indian patients, may not be really right. So I am of the firm belief that we have to Indianize Western guidelines as far as protein restriction is concerned. If you find that your patient is already malnourished, and if the patient is not doing very well with a creatinine of 9, then in that patient, one should not go with a VLPD approach right from the beginning. And if you are going with a LPD approach, then these patients would require definitely supplements. So if you are not using supplements, then VLPD approach is not good. But if you are using supplements in the right dose, again, we are using supplements in very, very poor doses, and the dosage required for keto analog supplements is very, very high. 24 tablets per day is the recommended dose, which is impossible as far as Indian patients are concerned. So we have done studies with lower doses also. So if you have a Indian patient, as the question is asked for our situation, creatinine of 9, then I would suggest that don't go for VLPD. Go for LPD with a keto analog supplementation if possible, and that might give you good results.
Thank you, sir. Thank you. Ma'am, we'll just take one last question as okay. Is bleaching completely removes the potassium? And there's one more question that the opinion regarding the nephro-related supplement, protein ONS supplements.
So, potassium bleaching is not required for all the patients, one thing. And you cannot prescribe bleaching as a single blind rule for everybody because potassium does not get completely leached from any fruit and vegetable. Also, we are losing other nutrients along with the leaching process. So, the best is try to counsel the patient about the foods or the vegetables which are high in potassium and try to systemize the intake of those portions so that we are able to balance the intake of the potassium and the phosphorus. Also, another important thing is, Sir would agree on that. Potassium leaching actually does not help you much in your serum potassium levels. So I think, of course, rather than avoiding high potassium foods, you can advise the patient to freely go for the moderate potassium foods or the low potassium foods and did not advise the leaching. In fact, there's been a study done which actually says that giving potassium fruits to the potassium-rich fruits to the patient did not impact their serum potassium levels at all. For the other question regarding the ONS, it is your choice completely. Sir has already said that whey protein can be given. A lot of renal specific supplements come with low potassium and low phosphorus levels, which is actually going to help us. Many a times, you need to give mid-morning or mid-evening snacks to the patients, and sometimes eating does not become feasible for the patient, and that is where the supplements can help us. Also, if the patient is a strict vegetarian, and I am unable to give the high biological proteins in the form of egg or something else, then my preference, of course, would be the with the supplements which are renal specific, so that I'm able to balance with the other parameters of the intake as well. Thank you.
So I'll
Thank
have
you
two
so much.
comments. Can I make two comments? Quick.
Yes, 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 sir.
So one is about the question was, does the leaching process remove the potassium completely? The
Completely,
answer is
yes. Yes,
no,
sir.
it doesn't remove the potassium completely. So therefore, rest of the things have already been answered by Himali. Now,
Yes.
the other thing was related to the, can you repeat that, the second part? Second question?
Second question, the opinion about the nephro supplement. There
Yeah,
are the
oral
supplements
nutrition.
available. Yes, yes.
Oral nutrition. I feel that if the patient's appetite is poor and the caloric intake is not being met, plus if you find that generally speaking the patient is malnourished, then oral nutrition supplements do help. So you select your patient properly. If sometimes the patient's appetite is very good and you don't really need to give any oral nutrition supplements, but otherwise you must consider them judiciously.
Thank you, sir. Thank you, ma'am, and thank you, sir, for your answers and for your insights. You have answered with the evidences which are there. It was a wonderful session, and thank you all the participants for your active participation. There are so many questions from your side. Thank you so much. Pia can end the session with a vote of thanks. Pia, over to you.
Yes. Yes. I want to express my sincere gratitude to Dr. Devdatta Safikar sir, dietitian Himani Puri ma'am, and even Mrs. Aarti Billare ma'am, even the participants who has spared their precious time from their busy schedule to enlighten all of us. And last but not least, even I want to thank True Healthy People also. Thank you so much for the wonderful session.